cancer control, how the CPAC collaborative model works, talk a little bit about the strategic focus on person-centered perspective and what we mean by that, and share a little bit of some of the outcomes we have already based on the first 5 years of the partnership's mandate. One of the big outputs is our system performance report, which some of you may have received. And hopefully we can have a good discussion around cancer control and survivorship and what our plans are after you hear the presentation around all of the knowledge exchange work, which is largely the largest part of the work of the partnership is convening and partnering with stakeholders like yourselves. I think somebody wants in. Somebody want to open the door for her? So so just to get us started, we know that almost 1/3 of us will be told that we have cancer at some point in our lives, and so we're very familiar, and we probably heard that in every presentation. We kind of have to just make that statement. And it also speaks to why we need cancer control, because it's going to be such a exponential problem moving forward in the next 20 years. And that really the cancer control is really all about reducing the impact of cancer for Canadians. So what is our strategy is, if you can imagine in 30 years' time that fewer people hopefully will be developing cancer, more people will be treated successfully, and people that are treated and looked after in the cancer system across Canada will have a better quality of life. So that generally is the rubrics for all cancer control on an international level. Those are the 3 aims of cancer control from WHO, UICC, all of the world organizations. And just to give a little background of the partnership, because having been here at Princess Margaret and a clinician, I don't think clinicians have a very clear understanding of what the role of cancer control is and why we need cancer control. So I just wanted to say that we really actually are a small entity. CPAC gets about 1% of the health budget to help address things nationally across the country. So when you compare that to Cancer Care Ontario, for instance, who's dealing with the province, it's a very small amount of money. And so it's very important that when we're talking about cancer control, we're also talking about the entire cancer journey, from prevention right through to palliative end-of-life care. So there are big investments in the area of prevention, given that we know that that's where the biggest outcome will happen if we can prevent actually cancers from developing in the first place. So in 2006, the strategy came about from the federal government. In 2007, they were awarded their first mandate. It's about $50 million per year that we invest across Canada towards sustaining action on a shared vision around cancer control. So that's done in collaboration with provinces, with cancer centers, with leading researchers, and CPAC invests a lot of energy and resources into convening and running meetings and building consensus on what is actually the approach that would help improve things on a national level. And they were all very excited, as I am now, since I'm at the partnership, is that there is a second mandate. And their actual goals, their strategy goals, really go till 2037. So I think there's a good sense that as long as we're able to show our value in the cancer system by working with everyone, that they will continue to invest in us working with everyone to make the system function in a better way. So the partnership works through building partnerships, and there are sort of 4 primary mechanisms that we have embarked on in terms of how we partner with people. And this was not all clear in the first mandate, but now we have a very clear cancer control strategy with as you'll see, very detailed indicators and ways that we have to report how things are getting better. So how we get people to reach consensus on how to do this work. It's through multi-jurisdictional and pan-Canadian efforts, so working with more than one province or territory, hopefully using the same measurement rubrics or the same framework so that we can compare information, and one jurisdiction can benefit from the other. in terms of the lessons learned and knowledge exchange. It's appropriate for partnered assessment and response, so we don't do anything without partners. There are a few things we've done in terms of working with data and statistics and so on with existing research organizations. That the work is grounded in scientific evidence, so we're very much an evidence-based process organization, and significant in terms of the difference. So when we determine what areas we're going to invest in the partnership, it's based on what will be the impact that we can see will happen in a 5-year time period. So really it's about adding value to the cancer system that already exists, and to improve the effectiveness and efficiency of what's already happening. So we're not really designed to come out and say CPAC knows the best method and the best approach and we have money to do that. We really say, you know, what is the framework we're going to use when we approach organizations? Where would we invest? Where would be the biggest impact that we could achieve with a certain level of resources? And so we work with 13 jurisdictions, provinces, territories, 200 types of cancer organizations, medical, social, and public policy organizations. And there are a number of things that were identified in the strategy plan that's the framework for how we work now in the partnership, and that is really some key areas that have been identified. And one is the actual burden that exists in our First Nations, Métis, and Inuit communities, that they have a much different cancer control situation than we do in urbanized Canada. So we know that the conditions in rural and remote areas are also a big issue in terms of the quality of cancer care that's delivered and what's available. So we have some very clear, many of our initiatives all across the partnership have a clear alignment with rural and remote issues, and they have a clear alignment with how we're going to do a better job working with the First Nations, Inuit, Métis communities. And that may change in the next mandate in terms of other priority areas that get identified. I think the reason for the strategy is we have to pick an area that we can focus on. We can't fix everything at the same time. So hopefully with the strategy and the approach we're taking in the partnership, that things will change in 10 years' time, that there will hopefully be more consistency in the approach that's taken as to how people are diagnosed, how they're cared for, that there'll be improved access or pathways for how patients receive cancer treatment, that we're going to work more collaboratively with researchers, and more people will be getting checked and being detected earlier, and again, the First Nations focus. So this is it's a hard slide to read. It's very detailed, but it's really there. You have it in your slide deck. It's also available online. Much of the information, the work of the partnership, is on CancerView, is on the partnership website. I would encourage you to go there. It's actually a resource there for researchers and clinicians, particularly CancerView, where we host all of the documents, reports, materials that could be helping you in the work you're trying to do. And the goal is really to be that repository to share with everyone. But this looks at the strategy in terms of clear outcomes in cancer control, right from prevention, right to diagnosis, treatment, survivorship, and palliative care. And those dots represent the target areas where we're working on indicators that we're going to report on, where things are actually improving. And everything in the work of the partnership is tied to that strategy, including every staff's performance. So all the work they do has to speak to how it addresses things in the strategy. It's a very interesting way to deliver on what's expected. That we have 5 strategy priority areas, and in terms of population-based prevention, high-quality early detection, person-centered cancer journey, and I'm going to go into that in more detail what we mean by that. Targeted research about cancer and chronic disease, and the First Nations community. Can everybody hear fine? Or are they having problems? Okay. Okay. There are core enabling functions as well, so mechanisms within the partnership where we've invested in resources and tools to help us to be able to report better on what we're learning across the country, and also better support the stakeholders who are working with us. So this is the logic model that it ties in very closely with the strategy plan, and you'll see at the bottom all of there are intermediate outcomes, immediate outcomes, and ultimate outcomes that drive us to the ultimate goal of decreasing the incidence and improving the quality of life and earlier detection. So all of those indicators all of those areas have clear indicators that are going to be reported on in terms of how we're actually doing in those three areas. And you will have seen that in the systems report that came out last year. If you don't have it, it's a good read. So the cancer control strategy, as I said, it's enabling a shared process because we don't really have universal health care. We don't have a universal cancer system. Every province and territory decides how they align their resources with their goals and what they need to do, and so there isn't much opportunity for them to be together to actually say, well, if maybe there's something to be learned by how you did that. Maybe there's cost savings and efficiency, and maybe if we did something together, like Manitoba and Ontario, that maybe the people in the north might have better access, and it might be cheaper in the end. So those kinds of things are part of the reason why we feel this shared partnering approach, and we do that through patient organizations, cancer organizations, research, and federal, provincial, and jurisdictional health ministries to try and drive the agenda forward by convening, by trying to look at my word there, by integrating, thank you, I get new glasses right after this presentation, and catalyzing the consensus around what is the best way. So if we all agree, it's a little easier to move forward and less competitive. And we want to be the broker of all that learning so that people everything at CPAC that's paid for, it really is a transfer payment from Health Canada, and everything is open access. So we don't sign any contracts where we don't have access to the IP or shared access. So just a little bit about our successes so far in the last 5 years that we've really moved forward on the agenda for cancer research. You may be aware that there's a conference coming up. Jennifer's presenting at it, CCSRC, which is a big meeting. I think there's thousands coming to that meeting. So if you're not signed on to that, I would get some information on that from Jennifer. And another big area is connecting evidence to practice. So you'll see on cancerview.ca a number of documents, including some that were produced by many of the people that sit around this table, Audrey and Doris Howell, and in terms of evidence-based guidelines for patient education, for survivorship care, fatigue management. So those are all really good examples of the tools that were developed, and now we're at the stage where either we have to update those guidelines, but the bigger question is how do we get to the point of programmatic response? In other words, who's adopting those guidelines? How are they using them? How are the patients benefiting? So improve reach to First Nations communities, and that's a really interesting lesson that the partnership has had a good track record of where others haven't, and that is it's a very different approach working with First Nations and Métis Inuit communities where we really we can't go about it in the traditional way that other people have thought of, that basically we can't do anything without actually meeting with them and hearing about their life situations and wrapping that into some kind of storyboard approach as to how we can safely move forward in a culturally safe way. So learning actually a lot from First Nations as to how we actually could do a better job at communicating in general around how we deliver healthcare. We have a lot of consensus around common reporting tools. So screening is a good example of that, is that there are clear frameworks and screening templates for how screening needs to be done in a consistent way, so it isn't done differently in Ontario versus BC, and that we can compare the data evidence-based across the country. We have a national colorectal screening is a really good example of that, and where we've seen actually big progress based on the implementation of a clear strategy for awareness around colorectal screening and how it's done and what is the uptake for in terms of rescreening. And so now we actually have been able to demonstrate in less than 5 years how there are less people dying from colon cancer. So the system performance is another big sort of exciting piece of the partnership's work, where we actually have a division that just helps us produce the reports that are there to help you. So they pull out data from the Canadian Statistics Canada information, Canadian Cancer Society, along with other reports that we get from the provincial jurisdictions across the country, and we're able to produce very interesting reports. One most recently you might have seen is the systems report on the actual state of cancer control in major Canadian cities. And if you're interested in that, I can send you the link for that, because it's very interesting. It's never really been looked at by city, and there's great variations in how, for instance, the smoking rates and the screening rates are in different cities across the country. Research I mentioned, so I'll just go over that slide just in terms of the goal there. Now that we have some investments in the areas of cancer and chronic disease. So a good example of that is our Canadian Partnership for Tomorrow project, where it's the biggest investment the partnership has. It's in prevention, but it's also working with all of the major researchers, most recently the Heart Stroke Foundation, and are going to be working with the CP Canadian Partnership for Tomorrow. I'm trying not to use the little acronyms around the National Health Study. I don't know if you've seen the ads for that in terms of the Ontario Health Study, but that's connected to all the other jurisdictions that are participating, and they have recruited well over 250,000 blood samples in that study, which will look at Canadians across the country over the next 30 years as to who develops cancer, who develops chronic disease. So I'm going to switch gears now. I'm going to move from the big picture around the Canadian Partnership and talk to you a little bit about how we got to where we are, to where through consensus and agreement that we now have a person-centered perspective portfolio at the partnership. In the past, you might have heard, in the past number of years, you might have heard the work in Cancer Journey or been at some of those meetings, and where they focused on things in the survivorship area around, started the work around screening for distress, navigation programs. So there was research looking at what kinds of navigation, volunteer, clinical navigation, in terms of what was the, what did that tell us about the survivorship journey, the needs of survivorship care, palliative care. So that was a lot of exploratory work that was done, and it really was the basis for how we have a strategic focus on person-centered perspective. So, so great foundational work that was done there. And so there wasn't actually a division called patient care or survivorship or even clinical care. Now there's a division, because of the work and the learning in that first 5 years, there's a director of diagnosis and clinical care, there's my role in person-centered perspective, and there is a director in First Nations, Inuit, and Métis. So there is a big chunk now addressing the question around how we best implement some of the things that we've learned from a national perspective. So some of those things include the work that was done with ESAS and patient-reported outcomes, and so we have about 5 or 6 people or jurisdictions that have engaged and continue to engage in doing ESAS measurement or patient-reported outcome measurement, and that's going to expand based on some of the work we know is going to be coming forward, where we hope to have all provinces and territories engaged in some level with PROMS measurement. And the reason why that is because we know that's something that can be measured. We know that it's a tool for moving things forward. If we don't have data on what the patients are saying, it makes it very hard to argue why we need to improve things. So the standardization of distress, it was one of the outcomes in terms of being recognized as the 6th vital sign. So you're going to hear a lot about distress work happening and research in that area. I mentioned the guidelines, the frameworks that have come out of the cancer journey work. We continue to do work in the return to work area. You'll be hearing something about that soon. And all really contributed to the patient experience overall. This is just an example of the Cancer View destination, and really when you get in there, you really have to dig because there's a lot of stuff in there, particularly the Cancer View series, The Truth of It, which I know people here at Elixir are very familiar with that and have used it, but they really have taken now the direction where the work they're going to do in that area is around health professionals. So they've done some really amazing videos that you might have seen recently on Dr. Larry Liebrack and Dr. Lowe. So really, it's really there to try to represent the patient's view, and it's not there to censor the patient's view. So that, and it's, I know from my work in D'Souza that they are using the videos as teaching tools everywhere. So it's been a really excellent resource, and we'll continue to support that initiative. A new, if you're not signed on to Cancer View, you wouldn't be getting these updates, which is a new approach called Cancer Digest 1 and 3. And so every month there's a clear focus on what's happening in different areas of cancer, research, survivorship. In October, there will be a palliative care digest because it is the National Meeting for Palliative Care and Palliative Care Month. So that will be the focus. I think screening and cervical screening was a focus a few months ago. Smoking cessation. Yeah, you're following it. Okay. So another really good example of work from the partnership where we took work that we did and we were approached by Sunnybrook to try and tie the fantastic work by Mike Evans around that fatigue caricature. Hopefully many of you have seen it, and tying that to actually the guidelines that were developed with some of the people here at Elixir, so through CPEN. And so now I get to person-centered perspective. So there's a reason why it doesn't say patient-centered perspective, because they're making a purposeful statement, an intentional effort to say we really need to talk about them as people first. They're not just patients. If we don't start with that level of respect, we really are not engaging them the way we need to find out what it is that they need. If we just assume what they need is what we think they need as clinicians, we really missed a very important step. And there's a lot of work happening in person-centered approaches now, and coming out of the work in the United States, UK, and Australia. So what we mean by person-centered perspective is that, really making a purposeful statement that we're really talking about dignity and respect for people and their families, and that their perspectives are important, their values, their beliefs as to what's important to them. It may be more important to them that they have child care than it is that they come here to find out that they have cancer. Or, and we know that clinically, and it is respectful to try and figure that out with them first. So trying to see things through their eyes, trying to work with them rather than doing things to and for them. Much of the health system is designed to do things to and for patients. So I hear you're here for your blood work, you're here for your chemo, you're here for this and that. So it really actually depersonalizes the person. So if there is somebody who isn't having a very good patient experience, it's usually that person. Included is the role of the healthcare professional in person-centered perspective, because we can't solve these things without everybody around the table. And it fundamentally speaks to what we're seeing now in Cancer Care Ontario and other provincial organizations where they now have clearly identified a patient and family council, that they're involved not only at that council but in other ways and mechanisms through cancer care delivery to say we actually have them around the table. If they're not part of the design, delivery, and implementation, then oftentimes there's a reason why things didn't work out. So this real shift is not an easy one, and it's something that we are, by identifying it as person-centered perspective in the partnership, are saying that we have to begin the work to basically get people to start thinking of their patients as people first, and not the person with colon cancer, breast cancer, and so on. That we need to change things at all levels, individuals and families and communities. They don't understand cancer control, and they don't understand the cancer system. Health practitioners don't understand that this is the methodology that is going to do a better job at reaching patient experience organizationally in health systems. So there's a lot of buy-in, just like there was when I started here at PMH 9 years ago, when they didn't know what we were doing with survivorship. What is the survivorship? We all do survivorship. So clearly you can see there's a lot going on here that we needed to be doing. So the work plan and person-centered perspective is highly identified in 4 core areas. One is the overarching embedding person-centered perspective, not just in the work we do with stakeholders, but within the partnership itself. They haven't been thinking about this. They've been thinking about cancer patients. And then the 4 core areas, 3 of them are areas that haven't really gotten the investment that they need. So one is patient experience through patient-reported outcome measurement. One is how we can improve palliative care and start addressing or learning more about that transition in care between from specialist oncology care to primary care. And we still have investments in the survivorship area. We have a number of programs that are continued getting funding with a succession plan strategy attached to them. So we're not funding indefinitely programs. We are investing in mobilizing the system to make the change. So more details specifically about the initiatives. What I have learned about this process is that when an organization like CPAC needs to make available funds for quality and system improvements, it has to be done in a systematic and transparent way. So much of the work in the first year has been really focused, paralleling a similar process to CCIHR in terms of making sure we have a very robust adjudication process for how we look at not only what's submitted, what ideas are submitted, but how do they align with the strategy that we have? How are they going to result in better measurement? How are they going to result in knowledge exchange? What is their succession plan so that when the funding ends, does the program just end and then the patients don't have access? So these are the target goals by working multi-jurisdictionally. So that takes about a whole year to do it properly. Requires close to 100 people to adjudicate the 3 initiatives that we have in patient experience, palliative care, and primary care. So many of the people on this call may have actually submitted to these calls. So there's a reason why there's limited information there, because it's until we have our agreement signed off, which hopefully will be January, we can't really talk about who they are and the details, but we can talk about what the goals are and what we anticipate it's going to look like. So the goal in patient experience is really to get people to start measuring in a consistent way. So some do it once a year, some do it monthly, some do it every visit. So it's very hard to compare that data. So that's one of the issues. The other is a common set of measures. So getting agreement on at least things like distress, things like pain management, fatigue. So what are the core things that they're going to be measuring? Let's start there instead of saying they're going to measure everything. So that is where that work is focused, and also getting more jurisdictions on board to do that. Palliative care is really focused on 3 things. One is the earlier introduction of palliative care. And so how can we get people introduced to palliative care sooner? How can we make sure people are getting good quality palliative care? And how can we make sure that patients express wishes around place of death? In other words, how can we support them better comfortably at home to avoid unnecessary deaths in hospital? So those are very blunt measures, and hopefully by the end of this mandate we'll have a much better framework for what will be much more specific indicators that we can say things are getting better in palliative care. And primary cancer care integration is really a much more sort of young initiative in terms of there isn't as much known and as much available to really say what is the best approach. So we want to start at the bottom, like we did in the first mandate, and learn a lot about who are the leaders in that area, what are they learning, what do they know, and what are the best strategies, and to work towards hopefully a framework and a set of indicators that will help us do a better job at measuring that's happening. So this is just a landscape map to show you how the country is impacted by that $50 million every year for 5 years. So the little dots actually represent projects that are happening in all those jurisdictions. Not all of the cancer control is happening in every jurisdiction because people have different levels of capacity to be able to manage projects, to be able to deliver. So, but at some point, I think the hope is that every jurisdiction will have all of the dots. So that's but it does really speak to the impact that's happening, where we're actually contributing to the work of folks like Princess Margaret Cancer Care Ontario and across the country. This is an example of the logic model that and sorry it's so blurry, it's probably a PDF. If you want a clean version, it is on CancerView. And this is an example of what came out of the palliative care network in the previous mandate to set the direction for palliative care, where we actually designed the call for proposals. And so this is the framework for how we need to go about. We've agreed that this is, if we're going to have an impact in palliative care, we have to follow this direction. So we at least have that. In patient experience, we have work that was done just before the end of the last mandate around agreement on what is the measurement framework look like for patient experience. Not that we can do all of those things, but it helps identify where to start. So if we start and we are able to get agreement on the red items, then when that's in a more developed state, we can then move over to what we could be doing to improve things in the family arena and shared perspectives that other set of indicators over there. So we don't have agreement on those indicators, it's just an agreement on this is the framework to begin the conversation. So that will set the stage for some of the networking that will happen. From systems report, these are the kinds of things that we get to learn, we're able to produce based on the work we're doing. So it shows you, for instance, where patients are dying across the country, how many are dying at home and hospital and other. So without that, health administrators don't really have a mechanism to actually objectively state the current state of affairs. And so we can see that across the country what's happening in different jurisdictions in terms of that, why is it that one province is 65%, another one 70%, and so on. And are there rural and remote factors there? Is it a First Nations question? Is it an access issue? So here's an example of actually the data that's collected across the country based on the NRC picker, patient satisfaction scores that are collected pretty routinely across the country, and we're putting them together so people can compare what's happening in one province, so we can say to Canadians things are getting better overall or not getting better, or why is it that it's what can we do to improve things in that jurisdiction? Is it a resource issue, and so on. Again, more of the picker data. And you can see there's great variation in the picker scores around quality of life, which is consistently the most problematic outcome in terms of when you're looking at PROMS measures is patient satisfaction in different areas. So they've been able to move things up in terms of better screening rates, better wait times, but this is an area that we continue to struggle with. So so this really sets the stage for the work that we're trying to do, and we'll continue in the person-centered portfolio. Our goal is really to broaden the response and the thinking. An example there is that some of the discussions that might happen on a national level isn't about what is the right indicator, but what are some concepts and approaches or frameworks we could be using, like the concept of minimally disruptive medicine. What can we do to minimize the impact we have on patients, because some of our approaches actually are harmful. Lung cancer, who should be screened for lung cancer, for instance, is a really good example. And the concept of something like simultaneous care, the idea that we should be actually talking about palliative care at diagnosis, not waiting until that we see if they are palliative, and that way it becomes part of the everybody's at risk for cancer coming back, and it is something people are going to think about, and we're going to support you through that. So it's it's something to always consider, that it's not a conversation that you need to avoid, and because it will help with how we design the healthcare around that patient or family. There'll be continued support for survivorship. Right now, we still support Cancer Chat Canada. That is the online counseling program out of BC Cancer. They have memorandums of understanding across the country where different cancer centers are adopting that as a platform for them to provide virtual support for patients. And so we support that. We're supporting the development of the adolescent and young adult guideline work and clinical practice for the delivery of survivorship care for adolescents. The planning and stewardship of symptom management guidelines. So we paid for the first iteration of the guidelines, and every so many years they need to be updated. So we're going to be doing work to support that. Return to work, we have resources that we're going to be investing in that. And we have invested in the past in a quality palliative care training program called EPICO, which is designed specifically for cancer patients. And we funded about 10 workshops across the country. I think we've trained about 270 some odd palliative care clinicians, specifically in the EPICO model. We're going to continue that support and work on a sustainability plan for where EPICO curriculum can sit. How to get involved in CPAC? There's a lot of opportunities to be engaged in either committees, networks, patients and families can be involved in advisory structures and so on. It's all posted on the website, and I think that's it's great that it's there. It's also one of the downfalls, so that there's so much on the web, unless they go to visit they hit on the opportunities button, they wouldn't get the update around where are the opportunities there. So it's a good idea to check both for opportunities for RFPs that are coming out for research projects, networking and advisory roles, which are going to expand very quickly in the next year or two as they go in. We're now moving into implementation. These are some of the cross-cutting themes that get talked about at a national level. What is the best mechanisms for us to be able to do this? Is it frameworks? Is it guidelines? Is it inventories? These are the big ticket items where we can get some consensus to build a framework around how we measure moving forward. So that's where I'm going to end. I don't know what my time is. I wasn't checking.
No, you're good.
Am I good?
Okay.